let's talk about challenges. Dr. Gore, what do you think is the biggest challenge that you guys have had, whether implementation or your current practice, that again, that's for advice, but to say, hey, this is what I find is the most difficult part about telemedicine right now?
I think a big part is, number one, identifying patients that we have typically seen as in-person visits where we can still do some telemedicine visits. But number two is really the technology on the patient end and the patient comfort with it. And that may relate in large part to my patient population, but I also think it's an opportunity. So, I may have a clinic where I've planned all telemedicine visits and 30% of them get converted to telephone visits. But when I initiate the visit, one of the things that I always try to tell patients is, the time that you and I invest in trying to make the audiovisual, the video visit work is time that will pay off with our future telemedicine visits, as we continue to do this in the future. So I try to take this opportunity during COVID where my clinic schedule is not as crazy busy as it usually is because we've rescheduled a lot of the non-urgent patients. And I try to use it as an opportunity to help patients learn how to do the telemedicine on their end, because that's been one of the biggest challenges is technology on the patient side.
Dr. Spitz, biggest challenges?
I think the biggest challenge is the technical aspect, because there's always a potential that even if you have good connectivity, your patient does not, or even if you both have good connectivity, the platform might be suffering some sort of overload or some sort of error. So it's really important to have backup communication systems ready to go. And it's also really important to have staff that is preparing the patient for the upcoming encounter. Having the staff talk to the patient ahead of time to either ensure that they understand the platform and are onboarding, or if they don't understand the platform or don't want to use the platform, have provided the staff with a telephone number where they can be reached most easily for a FaceTime, or an email where they can be reached for a Skype, or ultimately a phone number where they can be reached for a phone call, and having that staff provide you that information behind the scenes so that if your audiovisual encounter fails, you can immediately toggle to the next line of communication without delay and without frustration. And both you and the patient understand that those lines of communication are open. And a lot of that is contingent on having your office staff there, either from their home or from a central hub, but still working with you with these telemedical patients. Don't make the mistake of thinking because you're doing telemedicine on your own computer, you're on the hook for the whole kit and caboodle. Just as with inpatients, when patients' charts were prepped and patients were prepped, this is still going on the telemedicine side of things in our practice, and it keeps that workflow very smooth.
Okay. Dr. Rhee.
Sure. So on a scalability point of view, our challenges are this, is the amount of volume that we are doing, does it really translate into efficient care? Meaning that does a telephone or video visit translate later to continued telephone video visits, or does it just create more work over time in terms of the throughput with face-to-face visits and that sort of thing? And so that's the challenge, is to prove whether or not the telemedicine actually increases capacity for those patients that we really need to be seeing versus those that don't necessarily need to be seen as a face-to-face. The other part I will say is, on a really exciting note, is the innovation that is occurring. I mean, it is unbelievable, the opportunity here to really look at everything from devices to genetic tests to markers, all the things we're talking about. Well, what of these things can replace a face-to-face visit? What are these things that can actually help us along the way? Because in the end of the day, if we can do this through a telemedicine means, as urologists, to do our routine cases or the procedures, whether it's to proctor or whether it's to teach or whether actually to do something with the advanced practice provider, these are the things that we're really interested in doing. And I think it, to me, is a positive challenge that I think we're embracing. We're looking at things like bladder cancer markers to really see which of these really do not need maintenance surveillance cysto, if you will, as an example. Which of these PSA, as a screening tool, is that really effective? We have different ways we're looking at genetic markers, and we have different devices we're looking at. We're looking at an at-home Uroflow. That's an app that basically we don't want to bring the patient. Neither does the patient want to come into the clinic to get a Uroflow done. These are just small tidbits, but it just gives you a window into the future.